Hi, I'm Cynthia Douglass. I am uncertain what type of introduction has preceded this video presentation, but I will just take a moment to apologize for its quality. Turns out I'm not a videographer, I don't understand lighting, and I was unable to correct for the glare of my glasses. So I'm sorry, but thank you for listening to this presentation. By way of background, I am an RNJD. My education and nursing experience is remote in time, and so I do not hold myself out as a nursing expert. I will defer to you as the expert nurses in this field and for the processes of this talk. I have been practicing medical negligence litigation defense work for the past 30 years. I've been representing doctors, nurses, hospitals, healthcare providers once they become the target of negligence litigation. I've also had the opportunity to be with nurses through nursing board investigations and in dealing with complaints focused on their care. That's been a particular area of interest that I have appreciated, and I think in part based on my background as a nurse. That is who I am, and so thank you for having me here at your 2021 symposium, and particularly to be able to talk to you about the legal challenges in nursing. I know you've been called upon to deliver nursing care in circumstances that have never before been considered. I think that you have had to modify care in ways that no one ever could have predicted. And so I think we are going to see some of that show itself in the time to come as some of these cases make their way into litigation. I think that you, over this past year, dealt with in much sicker patients, given that because of the pandemic, we were trying to hold off on non-essential procedures. So I think the patients you saw were sicker. I think the demands on your care were greater than we could have known they were going to be. So today I'm going to look at the issues that we've been seeing and try to understand the post-anesthesia patient requirements as it pertains to discharge and transportation. Part of our responsibility in discharging patients from subsequent to GI procedures where they have had anesthesia or sedation is to ensure that they have a driver who meets some requirements, who can understand the nature of the procedure they've undergone, the potential for complications, and can function in the best interest of that patient. The Joint Commission has been very clear with us about our discharge responsibility. They, of course, require us to discharge a patient to a responsible adult and to be escorted out of the facility. A responsible adult is identified as an individual over the age of 18 who is able to physically and mentally make decisions for the patient's welfare. Who is responsible for a patient's ride home? Well, that starts in the whole pre-procedure process. This is where before a patient has undergone any sedation and in anticipation of the procedure is made to understand and agrees to their responsibilities as it pertains to discharge. That they know that a driver will be required, an adult driver, somebody that is able to understand the nature of their procedure and is able to surveil them for the development of complications and to act in their best interest should any of those complications arise. Of course, I love it when a case comes up and there's documentation that includes a packet of pre-procedure education materials and that the patient has in fact signed a document stating that they understand their responsibility in providing a driver and they have agreed to do so and they are prepared to comply with the post-operative surveillance needs of the patient. That goes a long way in helping, in helping that ensure it happens. patients who agree to that, who are really made to understand the significance of it, are more often able to make that happen. It's only when we cover this in the pre-procedure period that if a patient fails to have a ride home or is unable to be discharged to a competent person, that we can shift some of the financial responsibility to them should they require hospitalization for surveillance, or should they require medical transport home. If we fail to provide this pre-procedure information, that may be then the facility or our responsibility to manage. We want to ensure that a patient not only just gets home, but they get home to a place of safety. And I've touched on that a lot. That is where there is a person that understands the nature of the procedure they've undergone, who has the physical and mental ability to understand the potential for complications, recognize the complications, summon assistance, and act in the best interest of that patient. How do we decide if a nurse has done what the standard of care requires? The standard of care is identified as what a nurse should do in certain circumstances. What a nurse, an educated, trained, experienced nurse should do in same or similar circumstances. There is an instruction that is read to the trier of fact that identifies when a nurse is negligent. I'm going to read that instruction to you, and it says, a nurse is negligent when they fail to use the level of skill, knowledge, and care in treatment that other reasonably careful nurses would use in similar circumstances. So that is the nursing standard of care. So we look at what a nurse should do, what a reasonably careful nurse would do in the circumstances that we are presented with in litigation. How do I find out what is that standard of care? Well, I go to a couple of sources. One, I look at the Nurse Practice Act. That gives me information to understand what the nurse's scope of practice was and whether they were functioning in that within that scope. I look at institutional policies and procedures and guidelines that govern that practice. I get a nurse expert. I get a nurse who is similarly situated in terms of their training, their experience, and the environment in which they function. A nurse functioning in a standalone, same-day type of environment where they might not have opportunity for patient admissions is going to look different than the nurse who's functioning in a large facility where there may be a teaching research facility where there are other kinds of resources. I'm then going to, once I've selected that expert, ensuring that the qualifications line up, that the work environment is similar, that then I will then give all my information to that nurse, asking that nurse to make a determination. Can you testify that the nurse complied with the standard of care, that the nurse used the degree of skill and training that would be expected of a nurse in that situation? So I don't necessarily make that decision, but it is the totality of those of the circumstances. But it is the testimony of the expert that is going to be persuasive as to whether or not the nurse complied with the standard of care. The more we can give the trier of fact in terms of setting up the environment, taking them back. Once we know a complication has occurred and there's a lawsuit, that's one thing. But we need to take the trier of fact back to the time when the events occurred. So we want to set that scene. We want to create an understanding about what was known at that time, what information there was, what patient education had occurred, and what the facts were that we were living in at that time. The best thing that I have to do that with is the medical record. Of course, the memories fade. Nurses often don't remember these patients. Sometimes they're not standout patients. You never even know that they've experienced a complication or that they've had to return for any further care. That is nothing to feel embarrassed about. I find that nurses in deposition feel awkward in saying, oh, I don't remember this patient. The patients find this single medical encounter where they've had a devastating outcome to be very memorable. Their memories are sometimes guided by conversations they've had with their attorneys. Their memories are guided by later learned information. And so we can see sometimes disconnect where a nurse does have specific memories. We see disconnect with the patient's memory and the medical record that was created contemporaneously with these events and without the threat of litigation. So that completeness of that medical record is such a great tool for us, and that's why we look for one that is contemporaneous, that is complete, that is concise, and that is consistent. We have times where we see inconsistencies amongst providers, and sometimes we see inconsistencies within the records themselves, something inconsistent with a narrative note in some other type of document, which I'll touch on that just a little bit later. In wanting to use whatever evidence we have to support our decision making, we look a lot at the record. We look at the custom and practice of the nurse. We look at the policies and procedures guiding their practice. I'm going to talk a little bit about the different types of conversations that I'm involved in. Involving the discharge of patients from a care setting like many of you are at. One is we know that we have to discharge a patient to a competent adult. Well, first of all, I'm going to back up even a little bit more. The call that I get, sometimes this will be a flurry of these in the morning, the conversations I have are patients who show up having been advised that they needed to have a driver and somebody needed to accompany them. Show up all prepped and ready for their procedure, but advise us that they do not have, in fact, anyone that can take them home. The difficult call there is that we have to tell them that we cannot perform the procedure, that procedure will have to be rescheduled. Patients don't often understand that. Of course, we then leave holes in busy schedules that is difficult to explain and produce sort of some management issues. So again, it's just important that we get patient buy-off in that pre-procedure education process. The call gets made, or the conversation I have is, well, I've got what seems like a very competent driver, but the driver is 17 years old. Maybe a child of a patient or a grandchild who presents, who has a valid driver's license and certainly can safely transport a patient home, but certainly doesn't meet the age requirement. I can do a lot with preparing some defense of the decision to discharge to maybe an underage driver when I can produce evidence of why that decision was made and why it was a good decision. In discussion with the 17-year-old driver, the driver was able to demonstrate understanding of the nature of the procedure, the potential for complications, who had the mental and physical capacity to act in the best interest of the patient. Any kind of documentation stating why you knowingly discharged a patient to an underage driver is helpful in that kind of defense and a decision that we can support. Again, we're looking at the ability of the driver to provide for the safety of our patient. That one we can deal with. We have, the question comes up, can we send patients home with Ubers, Lyfts, taxis? How about those shuttles that come from their assisted living facilities or other types of living facilities? While those kinds of drivers are competent to get a patient from the hospital to a stated address, we can't assure ourselves that they have the capability of understanding the procedure that the patient has been through, understanding that patient's kind of baseline functioning, that are going to be able to provide ongoing surveillance, that person is going to be able to recognize evolving complications and to get help or to act in the best interest of that patient. So I cannot buy off on sending patients home in those kind of transport modalities. There's the call that comes in that the patient's spouse is unable to drive, but they are waiting at home, ready, willing, and competent to be able to surveil that patient, understand the procedure, watch for complications, and are motivated to act in the best interest of that patient. But the patient's going to take an Uber or Lyft home because the spouse can't drive, is just physically unable to drive, doesn't have a driver's license. The hard part for me is that we can't then certify or we are not the guarantor of good outcomes, but we don't have good evidence to rely on that transport time is going to provide a protected environment for the patient. So my advice is get that waiting person at home who is willing to provide the ongoing surveillance for this patient. Have them Uber or Lyft to the facility, and then they can go home together. That provides some continuity of the surveillance of that patient from the point of discharge all the way through that post-procedure care period. I was in an interesting conversation wherein an of-age driver presented to bring their family member home who was able to demonstrate understanding of the procedure, who understood the potential for complications and was going to provide ongoing post-procedure surveillance and was motivated to act in the best interest of that person. However, in the course of conversation, we learned, I'm not sure how, but that there was an invalid driver's license. In fact, that the driver's license had been suspended subsequent to a DUI. So the question is, could we now, knowing that information, discharge that patient? Was that a competent driver? And I came down on the side that no, we do not have to surveil driver's licenses and make decisions about their validity or about the competency of a driver to drive an automobile. But once we had that information in our hands, we really did have some responsibility to act on it. And so my advice was, well, let's not let you drive, but you could both go home by way of a transport facility wherein that family member could provide the surveillance of that patient all the way from discharge and through the post-procedure period. And so I could support that, the decision to do it that way. I think sometimes we just have to be careful about what questions we ask. What about here's a case where we have a patient, everything seems to be going well. They have participated in all the pre-procedure education. They have bought into and signed off on all responsibilities about what is required for them for discharge, what the potential complications are, and were able to provide a driver and somebody who was able to act in their best interest. Unfortunately, on the ride home, the patient had developed severe pain and difficulty breathing. The patient had undergone EGD. That turned out to be a bit more complicated procedure than was expected, and unfortunately realized the very complication that they were worried about, and that was an esophageal tear. The patient was returned to the facility, the tear recognized, repair undertaken. The patient did realize a protracted hospitalization and realized multiple complications along that. And so, of course, that case made its way into litigation. And some of the nursing care that became the focus was patient and the spouse said that the patient had really never returned to her baseline. She was simply unsuitable for discharge home. We were able to provide some documentation about the assessment of that patient, both their pre-procedure baseline, post-procedure baseline. The patient was identified as pain-free, and as there was some documentation about the patient taking and tolerating PO fluids. There was, however, some disconnect in the documentation. There was some inconsistencies, there was some late entries that made that documentation a little bit more difficult to work with. The other side put on a case that was persuasive, that established that the patient really had not returned to her baseline function. They put on a case that demonstrated that that procedure took about 3 times longer than it would have been expected to have taken, that the patient required much more pain medication inter-procedure than was expected, as well as post-procedure. The patient had been medicated for nausea and vomiting. They highlighted the idea that the patient was discharged home just 22 minutes after the procedure was documented as having been concluded. They were highlighted the idea that this was a procedure done later in the day, and that they felt that this patient's discharge was simply hurried to accommodate the closing of the facility for the day. The totality of those circumstances were persuasive. It was identified, and the nursing expert, that there's simply in that 22-minute interval and the time passage between medicating the patient and the discharge, there really was insufficient time to assess whether or not that nursing intervention was efficient. And so, because of the inconsistent medical records, some of the late entries, some of the patient testified vehemently that she was never offered PO fluids, and that she could not tolerate any fluids. I don't think she meant to lie. I think that really somehow had become her memory, though we had some evidence that in fact she had been offered and tolerated swallowing fluids. It's just our presentation picture had some inconsistencies, and the weight of the evidence was that it was a difficult procedure. Another piece of that I want to bring up is it was identified in the procedure report that was a difficult procedure, that there was some tortuosity, there was some difficulty in passing the scope that increased the risk of the development of complications from this. The nurse couldn't have known that, because that procedure report wasn't even available to her, the nurse in that 22-minute interval. And that's where the interprofessional communication becomes really important. Talking to the providers and understanding what went on in the procedure that might influence your recovery of and assessment of that patient for their competency for discharge. So again, it's just that focus on that contemporaneous, complete, consistent documentation, that pre-procedure setup for patients to do well. Our ability to say, no, we can't perform a procedure if a patient can't provide evidence that they have that driver. Our ability to make that 911 call when a patient is going to leave without a driver, who's leaving under the influence of anesthesia or sedation that makes them a risk to themselves or others. Those are all issues that I think we need to be thinking about in our facilities. Something that's come up that isn't concluded on my PowerPoint, but something I wanted to talk to you a little bit about is the idea of recordings being made. Over this past year especially, we have gone from a lot of face-to-face contact to telephonic interaction and other electronic interactions. A lot of facilities will have in some of their admission documents that videotaping or audio taping is, or recording, how old am I, is is expressly prohibited. We all accept that you cannot be recorded without your consent. We have operated under the legal theory that those types of improper recordings are inadmissible as evidence. However, over the past years, some of those recordings have made their way in as evidence for varying reasons, reasons that we're continuing to watch and wanting to consider. I had a case where it was identified in discovery that there had been a phone recording of a procedure wherein it was expressly noted that no recording was, that all recording was prohibited. My instinct was to not allow that piece of evidence to be admissible. However, when I reviewed the recording myself, I could see that it was so useful. I allowed my expert to review it, and all agreed that that videotape was really great evidence that the nurse had not only complied with the standard of care, but showed extraordinary measures taken by that nurse that showed exceptional professionalism, kindness, and grace extended to that patient. And so ultimately it was allowed in, and it was identified to be a very persuasive evidence in our defense of that. So what I want to say to you is I think it's worth considering what you want to do in terms of addressing this issue in a pre-procedure education with patients, including statements about prohibiting recordings. We saw recordings surface where a patient was not only recording their interaction with a physician, but actually was recording another person's interaction with a physician. And despite our best efforts to create privacy screens, we know with recording capabilities, sometimes there's audio that can be captured. So one is that be watchful about those recordings. A lot of our interaction electronically, there's recording capability. It can be recorded without our knowledge. I've noticed more recently when I've been on certain platforms, if you hit the record button, an announcement is now made. That hasn't always been so. So we want to be aware of our communications with patients, the ability to record them, have some forethought about what we want to, positions we want to take about recording, how we want to manage some of these recordable platforms. Be emboldened to identify people who are recording surreptitiously, to stop that, and consider that as our conditions of admissions of these patients. So in closing, thank you so much for this opportunity. Again, I hope that we could do this face-to-face sometime in the future, as I find our real-time interaction is so much more meaningful than me just talking at you. I know I've covered some topics. I know I might have misstated something. I might have been maybe not clear or complete on something, and I would welcome your continued dialogue with this. Please feel free to contact me if you want some further information or need clarification. If you want to have further discussion about some of this that we've talked about here today, I would love to have that. I know that we're going to have a little bit of question and answer time following this presentation, but I don't know if we can wrap everything up with that. So I do invite your continued conversation, and look forward to some face-to-face time in the future. I can't imagine what you've been through over these last year, and appreciate the integral role that you play as nurses in the delivery of healthcare, and we'll be looking to work with you as we manage some of the issues that will come out of the extraordinary circumstances that you faced over this during this pandemic. So I look forward to seeing you in the future, and thank you for your time.